Joining us for this week's Your Health segment is Dr. Matthew Weir, professor of medicine at the University of Maryland School of Medicine and nephrologist at the University of Maryland Medical Center. Doctor, thank you for being with us.
It's a pleasure.
We want to focus on the kidneys. We each have two of them. What happens when something goes wrong there? When we talk kidney disease, what are we talking about?
You know, your kidneys are really mainly there to filter the blood and make it clean. They also get rid of excess water you consume and obviously the proteins in your diet. But the real problem is if the kidneys don't clean the blood well, the blood can then be very injurious to your blood vessels. And so what's quite interesting is that an objective measure of kidney function, which can be done very easily with a simple blood or urine test, is highly predictive of your risk for stroke or heart attack. So people with kidney disease are actually at much greater risk for stroke or heart attack than they are for progression of their kidney disease.
So while it may be easily diagnosed with urine test or blood test for the patient, they generally have no idea anything is amiss.
It's very unusual for people to have symptoms very early on in the disease process unless it's a very catastrophic form of kidney disease, which can rarely occur. Most kidney disease is a chronic, insidious, slowly progressive process, which robs you of your vitality as the cleanliness of the blood declines. And so most people don't know until too late.
What's the role of high blood pressure in this?
Well, the major issue with high blood pressure, it can be both a cause of kidney disease, but also a result of kidney disease. But the leading causes of kidney problems that we see are really an interrelationship between diabetes and high blood pressure.
Which are also easily diagnosed. Is it something, if diagnosed early, is there an advantage in kidney disease cases? What treatments do you have?
Absolutely. I mean, obviously, the big three that we look at for the care of people with kidney disease are blood pressure, blood glucose, and their cholesterol, because they all come together to injure blood vessels and can lead to heart and kidney and stroke problems. So what we really try to do is to gear much of our efforts to control those three things. And then if the person also has another kind of kidney disease, which could be immunological in nature, then we can specifically target that.
Let me remind our viewers, if you have a question about anything to do with your kidneys, you can give us a call. We'll have the number up on the screen. You can also tweet your questions. Twitter address is @MPTNews. Why do we have two of them? We have one liver, one spleen, two kidneys.
Can't answer that question, but not everybody has two. But you really only need one good one, and it's the net number of little filters within the kidneys that really is most important for filtering and cleaning the blood.
So in cases of a kidney transplant where either the donor, a living donor, gives up one or the recipient just gets one, does that one work harder? Does it enlarge? Does it do something to adjust?
Actually, the younger the donor is, the more likely the kidney will hypertrophy or grow and start to accommodate more work. In fact, we have used very small pediatric kidneys from very young, unfortunate donors into an adult, and it'll grow right to the adult size. And even the remaining kidney in a donor increases its effort probably on the order of 20 to 30%. So there is a natural compensatory response to reducing the total number of filters if you donate a kidney. And we have good data now with kidney donors going out 40, 50 years showing that there is no adverse longitudinal outcome in terms of their overall health.
Kidney disease, does it affect certain groups, certain populations disproportionately?
Definitely. We have known that kidney disease can certainly affect people of African heritage more commonly than others. We have now learned that there are specific genes that people carry, which came down through history in large part because it prevented the risk for sleeping sickness in Africa. And when those genes are carried forward, they also increase the risk of kidney disease by as much as 10 to 20-fold increased risk. So it's very common to run in families. So we have to be very cautious about that. Also, Native Americans also have more kidney disease as well, and certainly anybody with, as I mentioned, problems with diabetes.
So grab a phone call. Baltimore City, this is Gail. Gail, thank you for calling. Go ahead.
Hi, Dr. Weir. It's Gail Gibson calling. I just want to thank you for all the good care that you've always given me. And I wanted to ask you, I'm in a lot of pain. I have some pain that goes from my hip all the way down to my leg, all the way down my shin.
Gail, I'm afraid I lost you there.
Okay, I have pain that goes down starts at my hip and it goes down my leg. Would that be possibly something to do with kidneys?
I would say unlikely not, save the possibility that you might have a kidney stone. Kidney stones can cause referred pain, probably not down your leg, but certainly into your groin or into the central part of your body.
But
the kidney stones can cause pain.
Do kidney stones relate to other types of kidney disease?
Well, it's interesting you ask that. People with kidney stones are at more risk for heart disease. There are studies illustrating that relationship. We're not really sure why, but it may be related to why stones form, either due to recurrent dehydration, higher levels of calcium in the blood. There are a whole variety of different possibilities.
Let's take another call. Baltimore City, this is Paul. Paul, thank you for calling. Go ahead.
Can you tell me how many people who've donated kidneys for kidney disease patients have ended up developing type 2 diabetes and eventually requiring kidney transplants themselves? Last time I checked, it was about 5 or 10 years ago, and I think there were a total of 40 then. There should be much more now.
Paul, thank you.
It's a very good question. We actually screen people carefully to make sure that they don't have any propensity for diabetes. So I think that's a very good point you raise, and it's possible that people who were screened in the past did not have a careful enough job doing that. It is true there are handfuls of cases of people who have donated and then gone on to require a kidney transplant themselves, but there are very few of them relative to the large scale of the number of donors that are done every year in the United States. We're very cautious and very careful in that regard.
Beyond transplantation, what's the most exciting thing happening in research now in your mind?
Well, I just came back from our national nephrology meetings in this past week. There are actually investigators who are actually harvesting kidney cells from somebody's kidney, growing them into healthier cells, and then re-injecting them into the kidney. So it's almost like using stem cells to have them naturally regrow some of their filters. So that's kind of a far-out, kind of interesting option, but it's actually now being done in people.
Wow.
In an experimental way.
Science fiction. Well, and for anyone worried about their kidneys, a basic checkup is going to include the blood work or urine work that will tell you if the kidneys are...
Oh, absolutely. I mean, even the National Kidney Foundation of Maryland here has routine free screening programs throughout the state. All you really need to do is get your blood pressure checked, get your blood sugar checked, and have simple tests of your blood and urine. It's very easy to screen. And again, earlier diagnosis, the better.
Dr. Matthew Weir, Professor of Medicine, University of Maryland. Sir, thank you for your time.
Thank you. Pleasure.
Appreciate it.
Your health segments are a co-production of Maryland Public Television and the University of Maryland Medical System.